Good afternoon, everyone. I'm Luis Ortega from Air Intervention, and today we have the pleasure for doing our 27th Air Intervention on Air. And today we have the totally privilege to host Dr. Francesco Cardaioli from the University of Padua in northern Italy. Beautiful place. Dr. Cardaioli, thank you for having us. We will discuss a study that he and his team recently published in Air Intervention, which is actually included within the special issue for the PCR London BAF that just ended yesterday. And the study is entitled The Long-Term Survival After TAVI in Low Flow, Low Gradient Aortic Stenosis. Very interesting clinical question. Dr. Cardaioli, welcome to Air Intervention on Air.
Thank you. Thank you for the introduction. Thank you for your kind invitation. It's a pleasure to be here.
Can you wrap up the study for us? If you can walk us through the rationale of the study, methods, key results that you found?
Yeah, for sure. We performed this retrospective analysis by using data from a single center registry, which is the Pure Valve Registry, which includes basically all the patients who underwent TAVI at our institution due to the presence of a severe symptomatic aortic stenosis. So for the purpose of the analysis, which is to evaluate the outcomes of different subset of patients inside our population, we divided our population into three different groups according to their baseline flow status and the type of aortic valve stenosis. So basically we had the high gradient aortic stenosis group, so patients who presented at baseline a mean gradient through the aortic valve greater than 40 millimeters of mercury. Then we have the paradoxical low flow gradient group, so patients with a low gradient aortic stenosis, and we preserve the ejection fraction. And then we have the classical low flow gradient group, so low flow gradient aortic stenosis with a reduced ejection fraction at baseline. For the purpose of the analysis, we decided to exclude some patients. So we excluded patients undergoing a valve-in-valve intervention, patients for whom the technical success according to the VALC-3 criteria was not met at the end of the procedure, and patients who presented a normal flow low gradient states aortic stenosis at baseline, because we believe that in this particular subset of patients, the potential for errors in echo measurement was too high. So we ended up including 574 patients in our analysis. 419 patients had an high gradient aortic stenosis, 91 had a paradoxical low flow gradient aortic stenosis, and 64 had a classical low flow gradient aortic stenosis. We considered as our primary endpoint the all-cause mortality, and also in order to adjust for possible baseline confounders for possible different baseline characteristics, we performed an adjusted survival analysis. We basically applied a propensity score weighted model to our survival analysis, which accounts for a number of different clinically significant baseline variables. So looking briefly at the results of our analysis, the mean age of our population was 8 years old. We had a median STS score, of 5 and a median follow-up time of 5 years. So if we look at our baseline clinical characteristics of the population, we can see that the classical low flow gradient patients were generally frailer at a higher surgical risk. Then if we look at the unadjusted survival curves, we can see that classical low flow gradient patients actually presented the worst survival across all the three groups at long-term follow-up. Moreover, when we look deeply at these curves, we can see that the three curves diverge in the first part, in the first year of follow-up, and then they run basically parallel. So we performed a landmark analysis from the 1 year mark onward, and we found that basically there is no significant difference in terms of mortality at a landmark analysis. So the increased mortality risk of classical low flow gradient patients was basically concentrated all in the first year of follow-up. Then we performed our adjusted survival analysis, and we noticed that classical low flow gradient patients had similar survival rates at long-term follow-up as compared to the other groups when we adjusted for possible baseline confounders. Finally, we found basically that among classical low flow gradient patients with a classical low-flow-gradient aortic stenosis, so with a reduced ejection fraction, basically 2/3 of this population presented a significant increase in LV ejection fraction after the follow-up, after the first year follow-up. By a significant increase, I mean an increase of at least 10% from their basal value. And actually, this particular subset of patients with an increased in LV ejection fraction after the first year of follow-up actually have also a longer life expectancy as compared to the other patients.
Okay, that's very interesting. I as we were discussing in the brief phase, I think it's a very interesting question. I would say that you found a way for a pure interventional structural topic. You make a clinical question, and it make it very interesting for all the readers, for people who do procedures, for people who do the imaging of the procedures, because it's a lot of echo. A key part of the assessment is by echo, and also for the clinical cardiologists that are there following these patients after this complex procedure. So, and this lead to my first question. We will open to a small Q&A. Dr. Cadaioli, what motivated you? Why of all the topics that we have in interventional cardiology, you devoted to go for this analysis on low flow, low gradient, and the outcomes after TAVR? What was the motivation?
Yeah, thank you for the question. So basically, we believe that low flow, low gradient patients are a real significant challenge for the interventional cardiologists nowadays. And they represent almost 20% of the patients that we treat every day in our clinical practice with TAVI procedure. So if you look at the previous studies published in the literature in this regard, they have shown basically inconsistent results on this topic. And moreover, they are mainly focused only on short and mid-term outcomes after TAVI. So basically with a follow-up of 1 or maximum 2 years. So we aim to contribute to this puzzle by providing data on the outcomes of this particular subset of patients after TAVI, and particularly we aimed to provide data of long-term outcomes in this population. So if you look at our study, you can see that we have actually the longest follow-up in this regard, with a median follow-up of nearly 5 years and a maximum follow-up of 12 years, which is a really long follow-up if you consider the actual high mortality rates of this particular population undergoing TAVI.
Okay, that's very insightful. I think that for all TAVR procedures, long term is always an issue, and especially for this type of procedures, low flow, low gradient, there are challenges, just not the diagnostic, just the procedure, and then the follow up. It's very demanding with all the follow up imaging that they need. And I think that having data beyond 5 years is I will not say mandatory, but it's very, very, very welcome. And
we are now starting to see that kind of data and that long follow-up in TAVI setting.
I congratulate your group for taking that initiative, and that linked me to the next question, which is, if you have to select, like the key message from your study about the, specifically the prognostic value of, which is the prognosis of these patients, can you elaborate on that? Can you say some, which is your key message of this of the results?
Yeah. We basically have demonstrated with our analysis that classical low flow gradient patients and paradoxical low flow gradient patients are actually two completely different animals in TAVI setting. Because if we look at our population and at baseline characteristics of our population, we can see that classical low flow gradient patients had a higher surgical risk, had a higher number of concomitant comorbidities, and were a frailer population as compared to the other two groups, which are really pretty comparable in terms of baseline characteristics. And these differences between classical low flow gradient patients and the other two groups, so high gradient and paradoxical low flow gradient patients, are also evident in terms of long-term survival, because actually classical low flow gradient patients were those demonstrating the lowest survival rates at long-term follow-up. However, when we adjust for baseline clinical confounders, we basically found that the mere low flow status is not enough to explain the higher mortality rates in this group. And probably so, the higher mortality risk of the classical low flow gain patients is more related to their failure, to their worse baseline clinical status, rather than the presence of a low flow state at baseline. And so our study is the very first study to point out this aspect, which is, I think, really important and really interesting from a clinical perspective, a clinical point of view.
Okay, I agree completely. One thing caught my attention for all your, the results that you have is that you saw an improvement of the LV function in this group, which I have to be honest, that is probably what we see in practice, but it's always, it's reassuring that we saw it, in a cohort of patients that is follow up, and this is in the setting of a clinical study. I think that reinforced the concept that these patients actually they improve after we do the procedure, because sometimes we even say we have to say, okay, we are not sure if this will help or not, but we will see,
Exactly.
and now we have some data on that sense, and I really appreciate that. And I will move to my last question, Dr. Cadaioli, and is I think is key, for all the studies is key about the key part is selection of the patients. You elaborate a little bit on the selection, patient selection role that you have in your study. Can you expand a little bit, explain more, and going into the clinical practice? So we are in clinic, we are seeing these three type of patients. How do you select them? How do you guide them to treatment? So if you can expand a little bit on that.
Yeah, thank you for the question, because this is probably the most important point of our analysis. So our results have clearly indicated that patient selection is the key to achieve a good clinical outcomes, a good clinical result in this particular subset of patients, which are at higher risk for adverse endpoints during follow-up. So we need to improve our ability to identify those patients for whom TAVI might be useful, and those patients for whom TAVI might be futile. So our data demonstrated that if TAVI candidates are properly selected, even classical orthogonal population may achieve a very good result in terms of long-term prognosis after the procedure. Unfortunately, given the small sample size of our analysis, we were not able to provide any insights about the role of each different baseline clinical variable in predicting clinical outcomes after TAVI. So, of course, we need larger analysis to confirm our result and to give us some details about which are the variables at baseline that are most impacting on clinical outcomes after the procedure.
Okay, I think that's very clear, and I think it's very useful for people who is doing procedures, for people who is following and diagnosing these patients. That when you refer these people to at the end TAVI results are spectacular, but it's a very invasive procedure. There is always concerns about complications, and it's always reassuring to say, hey, you are going to do something that will really impact your outcomes. You will live,
Yeah, exactly.
you will live more if you go through all of this. I really appreciate the results of your study. It's very interesting. I don't know if you have any comments on further studies or further analysis you are planning in these lines.
No, at the moment we're planning to do other analysis in other clinical setting, thanks to the data we have collected over all the past years, and in particular in this setting of classical orthogonal patients, we did not have any data about the role of contractile reserve in predicting clinical outcomes, because we did not have access to this kind of data in our population, and so this is a real important point which had to be addressed in further analysis also.
Okay. I agree, because it's something that is in the diagnostic pathway for this, but it's true, we don't know even if it's helpful or not for the prognostic part. I'm not saying the diagnostic part, no, but for the prognostic. Dr. Cadaioli, thanks again for your time. Thanks, and congratulations to all your team. We all know that research is a sport team, so there's a lot of people. All the names are in the manuscript. I invite all the readers to go to the special issue of PCR London Valve. Is very interesting. We're going from TAVR to mitral to tricuspid. LAO. So we have everything there. You can also swing by the website and check all the stories there. And you can, of course, see all the names of the collaborators of Dr. Cadaioli in the Padua University. Dr. Francesco Cadaioli, again, thanks for your time, for your dedication.
Thank you too.
Congratulations. And unfortunately, we don't see any questions from the readers, but Error Intervention account in Twitter and X is very active. Dr. Cadaioli also have a Twitter. I have a Twitter. So if you have questions, please just don't hesitate. Just tag us, and we will try to address them in the following days. So. For everyone, it has been a pleasure. Thank you. And we are looking forward for the next Error Intervention on Air 28 in the following weeks. Thank you, Dr. Cadaioli, and see you soon.
Thank you. Bye. Thank you.